Hello friends, today we'll discuss what's new in the PCP management, that is Pneumocystis carinii pneumonia management and prophylaxis in the new Fishman book, that is 6th edition. So coming to the criteria, so now they divide PCP pneumonia into three types, that is proven PCP, probable PCP and possible PCP. So proven PCP means that you are detecting the organism itself in either bowel or sputum or the lung tissue using conventional staining method or immunofluorescence. Probable PCP that patient is having at least one host criteria, one clinical feature and one mycological evidence. So host criteria includes existence of some condition like HIV, AIDS or other conditions which can lead to fall in CD4 count to less than 200. If patient is on T cell depleting therapy, if patient is on high dose steroids for a long term period that is more than equal to 14 days at a dose of more than equal to 0.3 mg per kg, then patient is having a history of solid organ transplantation. Among clinical features include respiratory symptoms like dyspnea, cough, and or radiographic findings. So the normal radiographic findings are bilateral, diffuse, fine reticular, interstitial opacification. These may appear granular, more commonly having perihilar distribution. Then patient can also have confluent GGO, but sometimes X-ray can be even normal. So that is why it is or. Then comes the mycological evidence, which includes positive serum 1,3-beta-D glucan, but it has to be positive on two consecutive samples, or there is a positive pneumocystis PCR assay on any respiratory tract specimen. Then come the possible PCP. So here you have host criteria, here you have clinical features, but there are no mycological evidence found. So one line that is negative serum 1,3-beta-D glucan, it has a kind of high negative predictive value for PCP, making the diagnosis unlikely. So this fact everyone should remember that a positive pneumocystis PCR in the absence of host clinical and radiographic criteria is not diagnostic. So in an immunocompetent patient with no symptoms, normal chest X-ray, no CT, and you are finding a positive pneumocystis PCR, it has no value actually. Coming to the presentation and mortality. So among HIV patients, clinical presentation is usually subtle despite the high organism load because they have a poor immunity and the mortality rate is high, 10 to 20%. Non-HIV patient, they typically presents with an abrupt onset of respiratory failure and the mortality is even high as compared to the HIV patient going up to 30 to 60%. So greater risk of death amongst cancer patient in part is related to the delays in diagnosis. Now, when we compare HIV positive versus HIV negative patient, so we come to few parameters one by one. So disease progression, it has a slower onset and a high organism burden in HIV positive patient as compared to HIV negative. They will rapidly deteriorate to type 1 respiratory failure even with a lower organism burden. The first line of therapy remains the same. It's just the duration that in HIV positive you have to give for 21 days at least. In HIV negative, you can see the improvement in the patient. So you have to give for an at least of 2 weeks, but it can extend up to 3 weeks also. Giving steroids. So giving steroids in HIV positive patient, it has a strong evidence if patient is having type 1 respiratory failure with a PaO2 of less than 70 mmHg. But in HIV negative patient, evidence is comparatively weaker and then it is just the clinician judgment if he wants to give or not. Clinical response, there is a gradual improvement over 7 to 10 days in HIV positive patient, whereas in HIV negative patients, it's the initial 48 hours, either the patient will have a faster response or patient can have a early deterioration also. Treatment failure, it is more common in HIV positive patient because of immune response to the dead organism. But if there is a treatment failure in HIV negative patients, you can think of an alternative infection or you can just revise your diagnosis. Risk of recurrence again is high in HIV positive patient if you are not giving any prophylaxis. Whereas in HIV negative patient, it basically depends upon the underlying condition that is producing immunosuppression. So prophylaxis is needed in HIV positive if the CD4 is less than 200, whereas in HIV negative, it is basically based on the immunosuppressive risk. We'll discuss in detail in next coming slides. So if we discuss the indication of PCP prophylaxis in HIV positive patient, the indication for prophylaxis are CD4 less than 200 or CD4 is less than 14% even when the patient is on ART. If the patient has a CD4 count between 200 to 250, then you really need to frequently monitor the patient. History of PCP and patient requires a secondary prophylaxis. So this were the indication in HIV positive. In HIV negative, if the patient is having a solid organ transplantation recipient, most commonly we see post RAR renal allograft recipient patient, or there are allogenic hematopoietic stem cell transplant recipients, or there are cancer patients on a prolonged high dose of steroids, or patient on these newer monoclonal antibodies, including alemtuzumab, PI3K inhibitors, temozolomide, or on radiation, or on some other alkylating agents. Severe primary immunodeficiencies like SCID, idiopathic CD4, lymphopenia. So the preferred regimen, which is used in prophylaxis of PCP, the first line agent, whether patient is HIV positive or HIV negative, it is trimethoprim and sulfamethoxazole combination, which comes in the name of Bactrim or Septran. It comes in two forms, double strength and single strength. It is basically co-formulated in a fixed ratio of 1:5, where 1 is trimethoprim and 5 is sulfamethoxazole. So in single strength, we have 80 mg of trimethoprim and 400 mg of sulfamethoxazole, whereas in double strength, we have 160 mg of trimethoprim and 800 mg of sulfamethoxazole. So in HIV positive patient, you can give one double strength tablet daily if you need to cover for toxoplasmosis also. But in cases where toxoplasmosis prophylaxis is not needed, one single strength tablet daily will do. The other alternative is to give a double strength thrice weekly. Coming to HIV negative patient, again, one single strength tablet daily or one double strength tablet daily or thrice weekly. The other alternatives, if the patient have intolerance to trimethoprim, sulfamethoxazole or contraindication, then we can give Dapsone, but prior to that, you need to check for G6PD deficiency. Then you have atovaquone, but it is slightly expensive and it needs food for a quick absorption or a better absorption. And the last drug, which is rarely used, is aerosolized pentamidine. It is least effective because it has a higher lung breakthrough. Coming to the duration of prophylaxis. So when to stop prophylaxis in HIV positive patient? So basically, primary prophylaxis, secondary prophylaxis. What type of prophylaxis you are giving actually? So primary prophylaxis, if you are giving a patient in HIV positive, then stop whenever the CD4 counts are more than equal to 200 for more than equal to 3 months. This is one criteria. Or if it is between 100 to 200, but there must be an undetectable viral load for 6 months. Secondary prophylaxis, use the same criteria. Coming to the HIV negative, coming to the most common patients that we see, solid organ transplant patient. So in these patients, 6 to 12 months post-transplant, it should be given. Allogenic hematopoietic stem cell transplant. Okay, one more point that usually for lung transplant patient, PCP prophylaxis is given lifelong. Then coming to allogenic hematopoietic stem cell transplant, again 6 months is needed at least. In cancer patient, till the time you are tapering the steroids or maybe up to 6 weeks post-steroid cessation, it must be given. Alemtuzumab therapy, so there must be 2 months of post-therapy, plus there must be CD4 count of more than 200, then you can stop PCP prophylaxis. For other like PI3K inhibitor, temozolomide, and ALL treatment, till the time you are giving active therapy, you should give PCP prophylaxis.